everyone. Thank you for attending the lecture after your lunch. And now we'll speak about the retinal issues which the patients face after an uneventful phacoemulsification surgery. So in my initial days, this was like this when I came out of the OT. Next day or after a week or so, when the patient is always complaining about visual complaints or some other discomfort, and we are confused ki what has gone wrong when the surgery was absolutely fine. So like everybody has said, it is divided into early and late phase. So in the immediate post-operative period, the problems which patients might face is post-operative iritis, the TAS, endophthalmitis, and the pre-existing retinal diseases which were missed during the initial evaluation before the cataract surgery. So post-operative iritis, many a times we get severe inflammations in patient where we find fibrin membrane and pupillary block kind of a syndrome, which is covered by madam very well. So in such cases, stepping up the topical steroids for the patients and adding cycloplegics helps resolve the condition within a few days. When it comes to TAS, there is corneal edema, there is hypopyon, there is FM, and there is a quiet eye apart from these syndromes. So in such cases, it is important to differentiate the TAS from endophthalmitis. So TAS typically presents with a blurry vision. It is usually 20 to 48 hours after the surgery, and we find corneal edema. Whenever it is there, it is limbus to limbus edema. And when it comes to endophthalmitis, the main patient symptom is pain, usually 4 to 7 days after the surgery, and there is focal edema. So this is a case presented 4 days after the cataract surgery, which was uneventful. We can see there is conjunctival injection, hypopyon is visible, lid edema is there, and when we see there is discharge and matted eyelashes. So this points more towards a picture of endophthalmitis, and on B scan we can see there are vitreous echoes, not seen very clearly here in the picture, but there was a component of vitritis also present in the patient. So such cases needs to be referred early to the retinal surgeon, and once it is referred, an early prompt treatment usually gives a very good result. So when it comes to endophthalmitis, we all know preoperative povidone iodine is the first line. Intracameral antibiotics are effective, and especially now we are using moxifloxacin. Previously cefuroxime was used, but now the organisms are resistant. And topical antibiotics usually lack any proven benefit when they are added perioperatively in a patient where the patient develops already intracameral antibiotics are used. We do use it routinely for all our patients, but the studies have not shown any added advantage when we are using intracameral antibiotics on the table during the surgery. And preoperative topical antibiotics we all start because we all are afraid of but studies have shown, at least in the Western literature, that there is no role of preoperatively starting topical or oral antibiotics in the patient where it can reduce the risk of endophthalmitis. So in the late post-operative period, we can have chronic low-grade iritis. So this is a treatment algorithm which I follow. In such patients, there is usually after 6 to 8 weeks after uneventful cataract surgery, once the steroids are tapered, they again develop iritis, photophobia, pain, and defective vision. So in such cases, we usually restart the post-operative steroid, and usually in a higher dose, maybe for 2 hourly, then slowly taper it over weeks. And when the inflammation is very mild to moderate inflammation, we usually go for a 6 weeks to 8 weeks of steroid taper. Then after 6 weeks, when we are seeing, there can be 3 scenarios. Once there is no inflammation and we can gradually stop it. Second is recurrent inflammation, and third is rebound inflammation. So once the patient had settled after 2 to 3 weeks, and then again there is a rebound iritis. So in such patients, going for difluprednate or a higher steroid rather than prednisolone has a better penetration and has a better action than predfort. So in such cases, also giving dexamethasone intravitreal implants can be helpful when it is recurring. In the initial stages, we can also give a posterior subtenons injection at your side where the inflammation gets controlled better. Then everybody talked about glare and negative dysphotopsia, for which the retinal surgeon gets a reference. The patient is complaining about something seen. The anterior segment surgeon doesn't see anything in the retina or in the vitreous, but the patient continuously complains. And mostly in the causes which Rajiv sir had explained, there is an illumination gap when the light passes through the IOL and through the edge of the IOL. So there is a gap which is not illuminated properly, which causes that crescent-shaped gap and a shadow in the vision. So in the early phases, early days, it is due to corneal edema, large angle kappa, or IOL designs. This usually subsides over 4 to 6 weeks to 2 to 3 months. And orientation of optic-haptic junction in the infratemporal plane is also being mentioned as a cause. All these features usually resolve after 3 to 4 months and just need reassurance. But if the patient is persistently complaining, we can go for reverse optic capture for such patients to reduce the distance between the iris and the IOL in the sulcus. So this can reduce these symptoms. PVD. Mostly my referred retinal patients are post-cataract for PVD. Patient is complaining about floaters, usually self-limiting. After a month or so, the symptom subsides because the brain adapts to that. But retinal evaluation by a specialist is required because we need to look out for any retinal breaks or any lattices or holes which have opened up due to the PVD. Treat the retinal breaks, and oral medication now available for vitreolysis, and YAG vitreolysis can also be performed when the floaters are large and only in the central area. And if the persistent complaints for the patient, we can give an option of vitrectomy for the patients. Coming to CME, which is most commonly seen, preoperatively the cornea, the retina was normal, then there is a edema. So the risk factors are uncontrolled diabetes, ERM which is missed early, diabetic retinopathy patients, and glaucoma patients who are on prostaglandin analogs, they have higher risk of developing cystoid macular edema. And when cataract surgery in the previous eye also had a history of CME, such patients we need to counsel them beforehand that your other eye surgery can also present with cystoid macular edema post-surgery. Treatment is again topical steroids and NSAIDs drops which we are giving. A posterior subtenon steroid injection helps a lot. And if after all this, if it doesn't resolve, then we can go for intravitreal steroid injections also. Usually I wait for a month for the symptoms to resolve just on the topical steroids as well as NSAIDs. And once it does not resolve, even after that, we can go for intravitreal or injections. Now, worsening of pre-existing retinal disease. Diabetes is known to progress after a cataract surgery, and patients with mild to moderate NPDR can develop cystoid macular spaces post-cataract surgery. And this also resolves nicely with our topical steroid medication. We need to wait, we need to give it time to heal. Just the patient needs to be explained about this condition. So many times due to dense cataract and poor visibility or dense PSCC, we are not able to find the subtle macular holes or ERMs beforehand before advising the surgery. In such cases, we might get unhappy patients post-operatively, but that needs to be explained to them whenever we see a hard cataract case where we are not able to assess the fundus properly. And there was a controversy regarding age-related macular degeneration progressing after doing a cataract surgery. But the recent studies have shown that there is no association between cataract surgery and wet AMD progression. So even after doing a cataract surgery, AMD will not progress. At least the patients do get a good vision after cataract surgery because the media is clear. But there is no association that doing a cataract surgery will worsen your wet AMD. Obviously, it has to be treated and there should be no fluid before we go for a cataract surgery in such patients. But it doesn't worsen what was previously believed. So thorough retinal and macular evaluation for patients with before cataract, effective preoperative counseling with, and setting realistic expectations like everybody said, and timely referral to a concerned specialist can give good results. Thank you.
Thank you very much. Thank you very much.